Hello, everyone. You're welcome to today's episode of our monthly webinar, the Glodem Training hosted by the Glodem Training Committee. Today, we're having to discuss bedside diagnostics by Dr. Wanat and Dr. Cyndy. So just a little bit about your hosts today. My name is Linda Atson. I'm a dermatology trainee in Nigeria, also the chair of the Glodem Training Committee. I have today volunteering with me Dr. Jamila Garib and Dr. Fortunate Raymond McCoy. So just a little bit about the Glodem Training Committee. The Glodem Training Committee is the trainee arm of Glodem, which is part of the International Foundation for Dermatology, the IFD. We promote knowledge equity by improving access to education for dermatology trainees across the world. We aim to provide free educational events and opportunities to build network and collaborate. So a little bit of housekeeping. Your audio will be muted throughout the duration of this webinar, and your cameras will be turned off as well. If you have any questions or comments, you can submit them via the chat function or the Q&A button. Our meeting hosts will share these with the speakers at the end of the webinar. We'll also be sharing further information about the Glodem Training Committee in the chat function during the webinar, so you can keep your eyes open during that to see more information. So I'm going to introduce Dr. Kari Wanat and Dr. Cyndy. Dr. Kari Wanat is the Glodem chair, and she'll be taking the topic bedside diagnostics and infectious diseases today. She's taking this presentation with Dr. Cyndy Muliro, who was a Glodem Training Committee member as well. So thank you very much, and you're welcome to today's webinar.
Welcome, everyone. We're so delighted that you decided to spend some time with us today. I'm delighted to participate in this webinar on bedside diagnosis of infectious diseases, as well as share the stage with Dr. Cyndy Muliro, who I'm delighted to be one of the Glodem mentees, for which I was her mentor. And I would say that this is very much of a co-mentoring relationship that we had, and really, really delighted that we can all be together. What we're going to do is I'll go through some of the objectives. We'll talk about bedside diagnosis using cases, and then I'm certain many of you may have some experiences as well that we'll want you to share, or any of your pearls or tips as well. So our objectives for today are to review the pearls in the use of bedside diagnostics, identify potential pitfalls in these diagnostic tests so you can sort of make sure that you feel good about what you are doing. And then we're going to apply these techniques to some important and interesting clinical scenarios. And all the clinical cases will be weaved throughout this. Now, the first question we may ask is, are bedside diagnostics important? Like, why should I utilize them if I'm not using them right now? And is there any benefit to other things, to using these compared to just our clinical acumen? And I'm hoping by the end of this webinar that you will understand that bedside diagnostics can help you make diagnoses faster and in an inexpensive way. They can be particularly helpful if pathology services are limited, slow, or if you're in remote locations. So it may take you a long time to get any results back from pathology, or if your clinical decision-making is really going to change based on whether or not something is infectious or not. And then it can really have a huge impact on care because we can start therapies earlier. The earlier we can start therapies, the better off it will be, because the patient will get the treatment that they need and not have the morbidity associated with the diseases that they may have. In addition, some of these infectious diseases are contagious, so that will limit the spread to other people from a public health concern. When we think about bedside diagnostics, sometimes it's like a little hard to wrap our head around because it could be a lot of different things. Bedside diagnostics can do anything you do at bedside. That can include dermoscopy, urine microscopy, Woods lab, if you do ultrasound. All of those things are things that you could do at the bedside. Today, we're not going to be focusing on those, but we're going to really focusing on techniques for which we actually are going to do something to the patient, either do a slit smear, a scraping, or a touch prep. And this is when we're thinking something could be infectious, but we're trying to exclude something else, or we think it could be infectious and could be on the list of diagnoses. And we really want to get to the heart of what could be going on. So by doing these sort of things, we're going to talk about these different aspects. And the good news about the slit, smear, scraping, and touch prep is that there's some similar strategies that we think about when we approach bedside diagnostics in this capacity. So when we think about this, the diagnosis, the breakdown of bedside diagnostics includes identification of best site and the technique to use. So why would you use a slit smear versus a KOH versus a ZANK versus others? The appropriate staining, because without the right staining, you're not going to get the right information. And then what you are visualizing when you do the stain. And for all of these, we will start with a case and then go through some of those techniques. The first case that we're going to have, and the first example is Dr. Muliro is going to start with her case. So Cyndy, off to you.
Thank you, Kari. So we'll start off with our first case of a 45-year-old male who came in to us with a 5-year history of skin disformation. This patient is a non-diabetes patient who was also on metformin. And this disformation was associated with redness, itching, and a gradual loss of sensation in the hands and the feet. This condition had been slowly progressing and recurrent without any necessarily triggering factors. He had no other history of any skin condition and no known history of food or drug allergies. So whenever he would get these symptoms, he would go to a health center. He was given the combination medication that has topical, systemic steroids, antibiotics, and antifungals. Then he goes home with no improvement. So by the time he was coming to us, he was quite sick looking and had generalized erythroderma. And this erythroderma spared the face, and it was associated with xerosis and scaling. He also had disseminated papular pruritic rash that spared the face, axillary folds, the genitals, the palms, and the soles, and also had excoriation that was quite marked on the abdomen and the back. At this point, we came up with a clinical diagnosis of erythroderma secondary to probably atopic dermatitis, rollout lymphoproliferative process, or scabies. So we started off from there. Went ahead, did several examinations, including a full hemogram, peripheral blood film, ESR. We did various imaging and microscopy. The full hemogram had elevated white blood cells. It had low HB and elevated platelets. We also saw features of caesary cells in the PBF, where we had presence of cerebriform nuclei, and ESR was elevated to 30. Chest X-ray and the abdominopelvic ultrasounds were non-remarkable. Same to the KOH was also negative. So at this point, we went ahead and collected multiple samples for biopsies. And the biopsy at that point revealed normal epidermis with granular infiltrates. So when we saw the granular infiltrates, we were quickened to think about Hansen's disease. So we went back and re-examined the patient again, now with a more Hansen's disease focused interview. So on examination now, we found that he had a glove and stocking paresthesia up to the level of the distal phalanges on the hands and the level of the ankles and the feet. And he also had a palpable ulnar nerve on the right arm. He also had lagophthalmos, and his palms were smooth and quite dry, with atrophy on the thenar and hypothenar muscles. He had also reported a history of erectile dysfunction. So at this point, we were quite convinced that probably he has leprosy. We went ahead and performed a slit skin smear. And yes, we found that it was positive, had a bacterial load of 3+. And we went back to the biopsy and performed a fetus stain, and we were able to also demonstrate acid-fast bacilli also on biopsy. So this went ahead and confirmed our diagnosis. We started our patient on the right multi-drug therapy for leprosy, and true to it, he got better and we had a good diagnosis. So this just goes to show the value of the slit skin smear and a proper physical exam when we see our patient. So I'll go ahead and just talk about slit skin smear very briefly. And we know it is a rapid, valuable, and cost-effective method of diagnosis. And we use it to estimate the density of acid-fast Mycobacterial leprae. And usually we report it as a bacterial index or morphological index. When we talk about the bacterial index, we are talking about everything that we will see on the slide at that time, be it the viable or the non-viable mycobacteria. while in the morphological index, we are only looking at the solidly stained mycobacteria. This is the viable bacteria. The difference is the solidly stained one is a proper rod, while the unviable bacteria tends to stain like in bits and pieces. So with this test, we are able to determine the severity of disease, we're able to determine the type of disease, and we're also able to assess if the patient is responding to treatment, because if we do it the first time and the patient had a high bacterial load and then comes back after treatment, we do it, the bacterial load has gone lower, we know that the medication is working. If the load is probably not going lower, we try to find out if the patient is adherent to the medication or if there is treatment failure. One of the things that we need to note about the slit skin smear is that it has high specificity and low sensitivity. The sensitivity has been reported to be about, on average, 70%. Go to the next slide. So while collecting the samples for slit skin smear, we have to be careful, or rather we have to remember the Mycobacterium leprae has sites of predilection. It likes cold temperatures, so it will tend to go towards the parts of the body where it's cold. So the most common part where we collect the samples from are the earlobes, the elbows, the knees. These are the extensor surfaces, the arms and the buttocks. And then you can also get samples from the chin and the forehead. And sometimes you might be required to collect the samples also from the active or suspicious lesions. So as you plan to collect your samples, you need to assemble your equipment. This includes your gloves, your sterile scalpel, your sharps disposal container, alcohol wipes or cotton swabs, your glass slides where you'll be able to fix your stain, and a flame for you to fix the stain. So you clean the area. Say, for example, what you can see on the picture is a sample being collected on the earlobe. So you clean the area with a spirit swab. Then you pinch the skin together with your finger and thumb. You can also use a clamp to obtain the same effect. What we are doing here essentially is to create an avascular area where we will not have blood coming through when we make our incision. So try as much as possible to create as much occlusion as you can, and give it a bit of time for it to have enough blanching. Then go ahead, make your small incision about 3 to 5 millimeters wide. And then after making that incision, ensure it is about 2 millimeters deep while you're making it also. Then turn your blade or your scalpel to 90 degrees along the incision line, and then scrap off the fluid that will have accumulated on top of the incision. What we want from the fluid most of the time, we want to avoid it having blood, but sometimes it is inevitable. So a little bit of blood is okay, but try as much as possible to ensure that it is as bloodless as you can make it. So once you collect the material, fix it on the, put it on the glass slide that you have labeled with the correct name of the patient. Make a circular motion to create something that is like, we say like a button. So it will sort of have like elevated edges and a center that is quite thin. And then gently hit the slide to fix it, and then stain using the Zn method. However, for staining of the Mycobacterium leprae, we use the modified Zn staining when it comes to microscopy. So we move on to the next slide. The slit skin smear is stained with a modified Zn stain, as I'd mentioned. So here we use sulfuric acid or acid alcohol as the decolorizing agent. So we stain the slides and we observe them under power 100 of the microscope. So you see, this is a microscope that you can use and is usually quite available in most of the facilities, even the basic facilities. You can be able to find a microscope that is power 100. So you'll either find the patient with lepromatous leprosy or tuberculoid leprosy. If it is lepromatous leprosy, you will see a lipid-laden macrophages that we call foam cells, or you'll be able to see the many acid-fast bacilli. Those are the red beautiful things you're seeing on that picture on the right. You'll be able to see a lot of them. And if it is on the severe end of the spectrum, sometimes it even has clumps and globes and globi. In tuberculoid leprosy, you might not necessarily see this acid-fast bacteria, or you'll see very few acid-fast bacteria, but you will see typical granulomas. So these typical granulomas are sufficient for a diagnosis of Hansen's disease. So when it comes to interpretation of the bacterial index, as mentioned earlier, the bacterial index, we look at the extent of the bacterial load. We do not want to know whether it is viable or unviable. We are just counting the number of bacteria we are visualizing under the slide. While morphological index, we are counting specifically the properly solidly stained acid-fast rods. So the ranges start from 0 to 6+. So anything 1+ and above is a positive finding, and it's a positive for leprosy. Remember, for leprosy, we need to have hypopigmented lesions. We have paresthesia, and the third cardinal sign is a positive slit skin smear. And thank you.
Thank you so much. That was a great overview, and what a great representative case of the importance of a bedside diagnostics to sort of help with that diagnosis. Thank you so much. And so that was great. That's the first technique we're going to talk about. And now we're going to move into the second technique, which is the zinc smear. And this is a characteristic example of a 35-year-old woman with a new painful eruption. We see these vesicles on an erythematous base. And many of us are probably already thinking we know what this could be. This could be a herpetic virus, could be either varicella or HSV. And I'm just highlighting this as an important case to do because I think when you're first using bedside diagnostics, performing on things that you know what they are will help build confidence and knowledge about what you're looking for. So in order to do a zinc smear, it depends on where you were looking for. In the case of herpetic infection, you want to go to the base of a blister. And so this is a video that demonstrates what we're going to do. So we basically unroof that blister. We get rid of the fluid because we don't necessarily want the fluid, and we're really scraping the base of the lesion. Once we have the base of the lesion, now we take that's the blade, and we smear it from a thick to a thin area. And if there's more contents available, then you would do the same thing from a thick to a thin area. Similarly, you would label the slide, you would evaluate, and I'll talk about the staining that we'll use. So here's when we think about the thick versus the thin smear. When we're looking for any of these things, the thick area can be really, really difficult because there are cells upon cells, but that's oftentimes where you have the most substance. And a thin smear where you actually can see the detail of individual cells is much easier. So really smearing any of these from a thick to a thin area allows us to visualize the nuclear detail that we need for a zinc smear or other items. Now, the other pearl is how do we stain? The staining of a zinc smear is basically a modified H&E stain. And so they have commercially available stains of a right Giemsa, a quick dip stain. Any of those that either Giemsa or right Giemsa that provides the contrast will be very helpful in seeing the nuclear detail that we're looking for. These are just examples that exist that are commercially available, but your lab itself may have something. Even a modified papanicula stain can be used when we're looking for the nuclear detail to identify the herpetic infection. When we do a zinc smear, we're looking at the nuclear detail for this, and this is an example of that zinc smear here. And in this example, when we're looking, we can see a lot of different cells in this particular case. We see these background white blood cells, which are very common infection. We see some background macrophages. And then what we're seeing here, a huge syncytium, a huge grouping of different cells. And these are keratinocytes that are much bigger than they normally are. So the size of these keratinocytes are a helpful clue, the molding of them together, specifically the nuclei, and the multinucleation of the keratinocytes are all keys of herpetic infection. Let's break this down a little bit further. So the visualization, the diagnosis of a herpetic infection is similar to what we see under histology, which is why I love this. We get acantholysis of the keratinocytes. They get a little bit squishy in some of those cases. We get ballooning of many of the others where they're infected and these virally transformed keratinocytes get huge. We get multinucleation where there are multiple nuclei where they're not, and then the margination as well. It looks just like it does underneath the microscope where you get these. This is an example of histology from a herpetic infection where we see these huge keratinocytes that are multinucleated, nuclear margination where the nuclear contents are sort of sucked to the periphery. That's also shown right here where you can outline the nucleus really clearly. All of those are diagnostic of herpetic infection. And doing zinc smears when you're in clinic or when you're not really sure about what's going on is really, really helpful because that will give you the antiviral that these patients need. There are other ways that a zinc smear can be used, and these other ways that the zinc smear can be used are also really helpful. And I'm going to give you another example of a patient of a 28-year-old HIV positive man with a new eruption. This morphology may look a little bit different than the last one, but there's some similarities where now we have vesicle pustules, we have umbilication in the center. You may be thinking, especially in a patient with HIV, there could be a whole host of different things that could be going on. You could still think about herpes, you could think about molluscum, you could think about cryptococcus, you could think about mpox. And by performing the zinc in the same way that we did before, where we unroof the epidermis, remove that, and get those contents and smear them on a slide, it can be quite helpful. So now let's look at this zinc smear. This zinc smear looks different than the one previously. We still have the white blood cells that are all in the periphery here. So all of these are these small white blood cells that look the same thing here. But instead, we have larger keratinocytes that are all located here. But these keratinocytes in this case are no longer multinucleated. And instead of having the nucleus that's sort of in the center with things around it, in this particular case, now we have all the nuclear contents, which are these bright blue areas, sucked to the periphery, okay? And we don't have the blue changes in the center. Because of the unique features that we see under this case and that are different than what we've normally seen in zinc smears, we also did a papaniculus stain. And the advantage of the papaniculus stain is that it will highlight keratinizing or epithelial cells in red. So all of these here we know are now the keratinocytes. And in this pap smear, we can see that these keratinocytes have all their nuclear contents sucked to the periphery. This is an example of mpox. And in this case, it was also confirmed by PCR. And mpox and the differentiation of mpox, especially now that the rise of the cases coming, the differentiation of mpox versus herpes versus other infectious diseases is really important because the treatment is going to be different and how we're going to look at it is going to be different as that. So you can get keratinocyte ballooning and you can get some multinucleation. However, in this particular case, the morphology of the nucleus and where those nuclear contents are different, okay? And so it looks different than what we saw in HSV. And this also looks quite similar to what it does underneath the microscope. So in mpox, histopathologically, you get basically extension of that epidermis where you get acanthosis, you can get spongiosis, and you get the ballooning of the keratinocytes where they get quite large. But here, the multinucleation and the change to the nucleus are different, where instead of having all those nuclei that are in the center, now all the contents are on the periphery. So these keratinocytes get huge, but you don't see the 3 M's that we see in herpetic infection. And those 3 M's being the multinucleation, the margination, and the molding that we see of the keratinocytes. Now, it's important that both mpox and herpetic infections are highly contagious. And in fact, mpoxes vary. The number of virions that you can have from one little area are quite large. So you want to use the utmost care when you're using sharps in these areas. And you want to be very, very cautious so that you don't get your own inoculation of mpox because of a sharps injury. There have been reports of cases like that, so you want to be very, very cautious when you're evaluating these patients and using all the standard precautions to take care of yourself. The zinc smear can be used for additional things as well. And the zinc smear, once again, using that counter stain to looking at the nuclear, can also be seen in molluscum contagiosum. Those umbilicated papules, pustules, vesicles. The differential diagnosis can include herpes, molluscum, and mpox. And so using this to help differentiate can be really helpful. This zinc smear, these 2 examples of zinc smears look quite different than we said in other circumstances, but also mimic perfectly what we see underneath the microscope of these virally transformed keratinocytes with Henderson-Patterson bodies. These are larger than we can see, and you can see that the nuclear contents are all sort of transformed in the same things. These ovoid, homogeneous, either basophilic or more purplish bodies are all characteristic, and nothing else looks like that. So in this particular case, the zinc smear can be really helpful in differentiating between those 3 entities that can be clinically similar to each other. So use that zinc smear and use it often. A best tip for both the zinc smear as well as KOH, in my opinion, is just scrape everything. If you're not sure if something's scaly, if there's a pustule, if there's a papule, scrape it and you'll get a lot of information from that. So now when we think about the KWH, and hopefully all of you have had experience in using KWH, the materials that we need are quite similar to what we needed for a zinc, where we have a slide, a 15 blade, the stains, and a microscope. But in this particular case, the stains that we're using are the potassium hydroxide, or I also introduced a stain called chlorazal black, or another one that can be used. Both of these stains will contain the potassium hydroxide that will dissolve the keratinocytes. In some circumstances, you have an additional agent of DMSO, which is basically a catalyzing agent for the destruction of the keratinocytes. If you do not have a potassium hydroxide that has the DMSO, but you just have plain potassium hydroxide, then those particular cases, heating of the sample, just like Cyndy had mentioned, heating of the sample can not only fix it, but can also help dissolve those keratinocytes so you can find the areas that you need. So just like in the first two examples, where you get the sample depends on what you are looking for. So when you are scraping, when you're doing something like a herpes or the lesion itself, you unroof and you get to the base of the content. When you're looking at KWH and you're thinking about tinea, you want to scrape the periphery of the lesion if you have an annular lesion. So in this particular case, you don't want to go in the center, but you want to go in the periphery of that. If you have a crust, you want to get the top area of the crust. And if a deeper process, you do a touch prep or a slit smear, as Cyndy had talked about. In any of the scraping techniques, I think it's helpful to wipe the area with alcohol, not only to sort of cleanse the area, but also, especially if something's scaly or crusty, it helps put that scalar crust in the area. Depending on where in the world you are, you could sort of think about if you have a lot of scale, you could either have a snowstorm, a blizzard of the snow coming off of that, or a sandstorm coming up, where if you scrape things and you don't have it wet before you do that, you can have tons of scale going everywhere, and then you're trying to catch it in different places. We don't want to do that. We want to have it in a controlled process. Similarly, if you have someone who you have concerns for onychomycosis, one of the best areas to sort of get is the subungual debris. You can also get a nail clipping, but then those nails are oftentimes really thick, and it takes a long time for the potassium hydroxide to dissolve the keratin that's present there. So let's go step by step for our KWH, because I think it should be the wheelhouse of all the things that you're doing. First, we clean the site with alcohol. That basically helps cleanse the area as well as put the scale where we want to have. We identify the area. In this particular case, we want to do the annular rim of this. And then we scrape the scale onto a slide. We only have to apply one drop of either the KWH or chlorazal black, heat if necessary, as we talked about, and evaluate. In this particular case, you don't have to flood the slide in order to get it present. Just apply it there. Let's look at a video to see how this can be done. And so this is an example of a case that we saw within the United States where we're cleaning the area. There's a scaly plaque on the dorsal hand. We have high suspicion that it could be a fungus, but we could also think about eczema. We are putting the blade parallel to the surface, getting the scale. There's not a blizzard or a sandstorm of different scale going everywhere. We can scrape multiple areas if we want. And then we have the contents right on the slide and we apply it there. That way, all of our scale is right there in the center. So when we apply the drop of the material, we know exactly where it's going to be. We apply a cover slip and then we evaluate underneath a microscope. I want to pause here and talk a little bit about the microscope setup, because this is also quite important. When you are doing, when you are looking at zinc smears or slit smears and looking for the detail and the small details that are present, you want to make sure that that condenser and you have is in the highest position so you can see all of that detail. For KOHs, where we are actually trying to enhance contrast, the difference between the background keratinocytes and the fungus that's present, we want to reduce the microscope illumination by lowering the condenser until the epithelial cells are clearly visible. And I'm going to show you some examples of this. You then scan on 4x to find the cells, and you evaluate the fungus under 10x or 40x to identify it. In the zinc smear, you're going to be looking more at the nuclear detail, so you need to find the cluster, but then you really are going into like the 20x or 40x to see that nuclear detail, similar with mpox or even molluscum as well. Okay, so the placement is critical, because if you do not do this, then you are not going to be able to identify the fungus. It will be very, very difficult. And in fact, one of the key things that I can do when I'm working with trainees is adjust the location of the condenser, because that allows us for easier visualization of what we're doing. Now, the condenser on your microscope may not be the same thing as here, but I encourage you to know where that condenser is and how to move it up and down. Oftentimes it's a knob that you can adjust downward. Sometimes it's a slide. Every microscope is a little bit different, but the idea is that you want to enhance the contrast and reduce it. So does this really make a difference? Well, here's an example. So it's an example of the same slide and the same location on the slide, same light, and just adjusting the condenser. You can see in this particular example, you don't see much on the slide itself, but then when we adjust the condenser down, everything is visualized. And so that power of just moving that condenser can be quite powerful. And then you can actually visualize the background keratinocytes and the hyphae that are present. So staining, we talked a lot about potassium hydroxide. There is also chlorazyl black, and the chlorazyl black is a counterstain to the fungus, and it will actually turn it the fungus turquoise. There's also Swartz lambkins, which will turn the fungus blue. Both of those will just enhance the ability for you to identify the fungus, and I'll show some examples of that, of how that will be helpful. As I mentioned before, there's DMSO, dimethyl sulfoxide, that will give a little bit more rapid maceration and clearing. But the preparations don't keep long. If you do not have potassium hydroxide, then heating the sample is really important to sort of help dissolving of that, so you can identify, you can evaluate the prep more quickly. So here's some examples of a positive KOH. There are hyphae. These hyphae are large branching units where you can see branching upon that. You can oftentimes see septations present, and they go across the cell walls. If you are forcing it, as I tell my trainees, it's probably not positive. If you have to look really particular and things like that, then it's probably not positive. You want to keep on looking to see if you can identify where there it is. Now, there are pitfalls when we think about potassium hydroxide preparations and identification of fungus. One of the most common ones that we see is mosaic fungus, where people will think that they see the branching fungus along the walls, but in actuality, these are the lines of the epidermal cells that dissolve into this branching network. So an example would be right here, right? This could be, you may think, oh, that looks like branching fungus, but in actuality, it's just following the lines of the keratinocytes. And so really you want to see it going across that. You want to see the septations or see the branching that may exist. And so with practice, you can easily identify that this is mosaic fungus and not true fungus that's present. So just to show the techniques of this, so with the chlorazyl black or the different stains, this is an example of chlorazyl black. And in this particular case, you can see that they're nice and turquoise. So in this particular case, it's easier to identify from the background keratinocytes, where there's not true. And so you can actually see the fungus that's present. So the hyphae will be turquoise, and this is an example of regular tinea corporis. And here's an example of tinea versicolor with some of the small spaghetti and meatball presents that are findings that are present. So you may think, oh yes, well, I know I can already use for tinea corporis and other things, but can this be used elsewhere? And is this useful in any other circumstances? And I would argue, yes, it can be useful in multiple different avenues. One of the examples would be chromoblastomycosis. Chromoblastomycosis is something that can be easily identified when you actually take a punch biopsy, but it can actually also be easily identified through scraping. So you may be anticipating someone have chromoblastomycosis because you have a verrucous plaque or a large, long-standing plaque, sometimes with ulceration. And the key for chromoblastomycosis to increase your diagnostic yield is actually to look for these pigmented areas here. These little pigmented areas are collections of those pigmented bodies, sclerotic bodies, medlar bodies, copper pennies, whatever you want to call them. And you use the same KOH prep that you would use for tinea corporis or tinea versicolor. You just scrape those little areas, you put it on, and you can visualize these quite easily. Here are examples of these copper pennies that are there, usually 4 to 12 microns in diameter. And this is an example of a prep that was sitting for a period of time after heating, so you can actually see the hyphae that are coming out of it. But a really exquisitely helpful way where you don't have to do a biopsy to identify the chromoblastomycosis. Similar to the other cases, I encourage you to scrape multiple different areas, because in scraping of multiple different areas, you can actually increase your diagnostic yield. So scrape those brown dots and identify it. I know that there are many cases in Indonesia where they're actually incorporating this right now with great success. Another example for people who may be in an endemic area in South America or Central America is patients with paracoccidiomycosis. These oftentimes can present in the oral mucosa, and also have ulcerated skin lesions. And in this particular case, paracoccidiomycosis does not grow well, if at all. And that's oftentimes because of competing flora and things like that. So the ability to do a scraping of this can be quite helpful. Even in the oral mucosa, you can actually take a blade and scrape the surface, apply it, and then apply the KOH. This is an example of a case that I saw when I was in Peru of the patient who had a paracoccidiomycosis. And in paracoccidiomycosis, you have narrow budding of the yeast forms. It can form either what they call Mariner's wheel, if you can imagine things coming off the side, or even if you know who Mickey Mouse is, where you have the little pinching of the ears coming off of the head of that. So an example of being able to use bedside diagnostics quickly to identify paracoccidiomycosis. Similarly, the chlorazole black or the Schwartz lambskins can also be quite helpful in making this diagnosis. Another example, which may be more pertinent to those people who are in North America, is blastomycosis. And so this is an example of a patient that we saw here, a man with no significant medical history who had changes on a face and in the setting of low-grade fevers and recent cough. A scraping was performed. We basically scraped the crust in this particular case of the more superficial area, applied it to the slide as we normally would do, and then used the chlorazole black in order to identify the things. And maybe you can take a look right now of where you think it may be. And if you identified it here, these turquoise, perfectly round hyphae, as well as another one located here, this is an example of blastomycosis. Different than paracoccidiomycosis, because now instead of the narrow budding, you have broad-based budding where they look like a snowman. So the pearl in this particular case is that chlorazole black is really awesome, where it can really help identify the fungus, especially when you're not sure between the two, differentiate between air bubbles and other cases that are there. So if you have the ability to get chlorazole black, great. If not, don't worry, you can still identify everything via KOH. I just want to show another technique that could be helpful when sometimes you may not know what's going on. This was a case of blastomycosis, but this woman came in with a verrucous plaque on the nose. She had reported some blistering in the past, some crusting, and we had a large differential diagnosis of whether or not this could be a persistent herpetic infection, if this could be a deep fungal infection such as blastomycosis, if this could be more of a deep fungal mycosis that can occur on the nose, if this could be even things like lymphoma or leprosy. So in this particular case, because we had a wide differential diagnosis, we did both chlorazole black as well as the zinc smear. And when we do the chlorazole black and the zinc smear, what we can see is that it doesn't really matter which technique you use because you may be able to identify it on both. So here's an example of the great, the sort of snowman look of a blastomycosis where you have two yeast forms with broad-based budding. And then also on the zinc smear, you can see a similar view of that. So in this particular case, in all of these examples, we were able to identify the presence of the fungus early and get patients on therapy quite quickly. A biopsy was performed in several of these cases, but that biopsy can take up to a week, and then tissue culture may or may not ever grow. Can it be used in other circumstances? And the answer is yes. Going back to an HIV positive man, if you could think about these umbilicated papules, pustules, and papules that are present with crusting overlying it, there's a long differential diagnosis, including herpetic infection, including mpox, including molluscum contagiosum. In this particular case, a zinc smear was performed, and much to our surprise and our ability to help the patient earlier, we can see these large cells, but we see these yeast forms here. And around these yeast forms, there's this clearing. And that clearing is the clear gelatinous capsule of Cryptococcus. And so in this particular case, zinc smears in all of these different cases can also be useful for fungus. And so scraping them and having two slides available so that you can stain them can be really, really helpful. Cryptococcus, as I mentioned, will be oftentimes a little bit smaller than other of the yeast forms. They're round, and then you have this gelatinous capsule surrounding all of them. The capsule will stain with methylene blue, allicin blue, and mucicarmine, but the gelatinous area will be clear, and the nuclei will also stain. You can also use an India ink, and that will be a negative stain. Will stain actually everything around it, but keep the yeast forms separate. So multiple ways for you to try to help your patients and get an earlier diagnosis. So the pearl in this particular case, as I say, scrape everything and use two slides. If you're not sure what the diagnosis is going to be and you have a wide differential diagnosis, smear the specimen on the contents of two slides, zinc one, and KOH or chlorazole black the other. And that way you'll get the most information that you have present. So we talked about a lot of these different deep fungal infections and wanted to just sort of give you a more general view of what to look for. what blastomycosis would look like, the size of them of 8 to 15 microns, variably derived. Coccidiomycosis, which will be in the Southwest United States, most often 10 to 80 microns. Cryptococcus, which is a little bit smaller and then has that clear gelatinous capsule. Histoplasmosis, which is really, really small. And in this particular case, Giemser or Zinxer is best. And they're really, really small, so you're looking for them encapsulated, basically engulfed in macrophages. And then finally, paracoccidiomycosis, which can be variably in size and will have the narrow budding. And you could either see the Mariner's wheels or Mickey Mouse. So in the last sort of technique that we want to talk a little about is a variant of sort of a slit smear or the KOH, and that's a touch prep. And the touch prep is really helpful when you're thinking about things that are in the deep dermis or even the vessels, and your scraping of the surface is not going to show you where that is. So in this particular case, we see in the morphology here of this woman with a history of Gardner syndrome who had a transplant and had solid organ rejection, was on high systemic steroids, and she had these painful plaques on the legs. Our differential diagnosis here is more of something affecting the blood vessels because we have these violaceous plaques and these ulcers. And so scraping the surface is not going to get the information. Instead, I need to get into the dermis and then even in the deeper dermis. So a slit smear could be used in this particular case where, as Cyndy mentioned, you pinch it and you actually get to that and smear the contents. That would be a perfectly acceptable technique. The other thing that we oftentimes do in this particular case is something called a touch prep. And a touch prep is something you can use if you're going to be biopsying a patient anyway, and you can actually try to get information a little bit more earlier. This is an example of a KOH from this patient. And in this KOH, you can see these more larger hyphae that have septations. And so we know that this is an example of probably Fusarium or Aspergillus in a patient who's immunocompromised. So in this touch prep, we basically remove part of the specimen that you would, like a skin biopsy. You take that piece that you'd be putting in formalin and you rub the base of that punch biopsy itself or the center of lesion on the slide before you place it in formalin. Then you let it air dry and then you apply KOH or Chlorasol Black. Alternatively, you could also, after you obtain your biopsy, you could also take that blade and scrape the dermal portion after completing the biopsy. That's sort of a variant on the slit smear. Or if you don't want to do either one of those, you could pinch like Cyndy had mentioned and perform the slit smear that you have present. By taking that specimen and applying it on the slide, you can then see the different hyphal elements that are there. It's really helpful when you're thinking about angioevasive fungus because even seeing fungus or not is very helpful. And seeing the presence of the septations can also be quite helpful in the therapy that you choose to use for these patients. And so the touch prep is a rapid diagnostic test that can help identify the fungi quickly. And so in this particular case, we took that specimen, we rubbed it on the location. We can sort of see where the hyphal elements would be histopathologically, and those correlate to what we see under KOH. The speciation is quite difficult, but seeing septations or not, seeing fungus or not, allows us to get the patient therapy early, including antifungals or debridement if necessary. So how do these different forms of fungus look underneath the microscope? Aspergillus will be more thin, acute angle branching with septations. Scedosporium or Fusarium also have septated hyphae. They are oftentimes branching could be 45 to 90 degrees. They have more bubbly cytoplasm. These are oftentimes in high quantities. And then the mucormycosis, Rhizopus, most common, but could have other agents as well, will be more ribbon-like. And this is an example of where Chlorasol Black was used, but the turquoise nature of it, because these were dying organisms, were not as bright. But you can see these are really, really ribbon-like, aseptite, wide-angle blanching, and usually a little bit more flowing throughout the area. So 3 examples of where this could be potentially helpful. So the touch prep tips that we have for this is Chlorasol Black really helps increase contrast if you have it available. Using a thick to thin spreading technique will help reduce clumping. So that same technique that you use when we actually did the scraping, you take your punch, your little punch, and you spread it across the sample. And then fortunately or unfortunately, specimens with the highest diagnostic yield are often the most friable. So as you're applying the specimen to the slide, if it breaks apart a little bit, that's okay. it's really important that if you're doing tissue culture with these cases is that you do not use the specimen that you're going to be submitting for culture for a touch prep, because it will be touching a non-sterile slide and you may get unusual results. So only the specimen that you are going to be submitting for processing via, in formalin, processing for histology should be used for that. So we did, I think, an amazing overview of the bedside diagnostic tips. The things that we want to know is scrape often and early, practice on the things you know are going to be positive so you can gain confidence and an eye for what these look like. There are some CME articles in the JAD that were published in 2017 that outline these techniques and stains and give you helpful pictures. And so those would be potential helpful resources for you as well. And then both Cyndy and I would be very, very happy to answer any questions that come up, or I oftentimes will get pictures of what of examples of things when people have scraped before, and I'd be very happy to take a look at those. So I'll stop sharing, and then I think we have some time for questions.
So we have some questions from the question and answer function. The first one is it says, are we able to distinguish colonization from infection with bedside diagnostic, particularly for fungal infections?
Yeah, I don't know. Cyndy, you can tell me if at any point you want to sort of answer, but yes, you can, because I think that also will be is important to know your clinical acumen, right? So if someone has an annular plaques with erythema and scale, that's not colonization, that's infection, right? So you're scraping to identify that. If someone has a purpuric plaque that's ulcerated and friable, and you identify Aspergillus fusarium, etc., then that's an infection, not colonization, right? And if you use the appropriate technique. Similarly, if you identify someone who is a ulcer crusted lesion and you identify what looks like blastomycosis, cryptococcus, things like that, none of those are colonizers. The areas that it can become a little bit more difficult is if you just have a chronic wound, if you have a chronic ulcer that's been present for a long time and you just scrape the center of the ulcer. I don't recommend you do that for any technique because that's not going to be helpful. So it's having knowledge of what you're clinically suspecting, performing the technique to see if something is present or not, and then marrying that information together to determine that something actually is a true infection as opposed to colonizer.
Thank you very much. So the second question comes from Chloe. It says, is it necessary to clean all lesions before doing bedside diagnostics? Does the various cleaning techniques interfere with diagnostic yield?
So I think the question was whether or not the various cleaning techniques will affect the diagnostic yield. The diagnostic yield for a bedside diagnostics shouldn't be impacted by the cleaning technique that you're using, because the cleaning technique isn't looking for viable organisms, meaning some cleaning techniques, if you use chlorhexidine, for example, that will kill bacteria, things like that, could kill fungus, etc. But I'm not looking at it to actually culture it thereabout. I'm just looking for the presence of it. So the cleaning technique should not have an impact on that. For ease and simplicity, I just use alcohol because oftentimes you have alcohol readily available. And so cleaning the technique, cleaning the surface with alcohol could be quite easy, but it does not impact the diagnostic yield.
Thank you very much. The third question says, how exactly do we hit the 20% KOH slides by Tapio?
Yes, I didn't include much because it's quite variable. So I've been in circumstances where things are heated on a heat plate. So if you have a heating plate or element and you can press the slides on that. Really, really important, you do not want your specimen to boil, okay? If you boil it, or you cause things and you will get fractures sort of in the KOH and it will not be helpful. So it's gentle heat. So you could use either a heating plate, you can use a lighter, which I've used in, when I've been traveling and I haven't had access to a heating plate, you can just use a lighter where like a cigarette lighter or whatever, like fire lighter, where you turn it on and gently heat. Similar, you don't want it to boil. You could use a Bunsen burner if you have a Bunsen burner that's present, and you want to gently heat. So by gently heating, the idea is you gently heat such that you could take that slide and put it on your hand, the back side of the slide, and you wouldn't burn yourself. Okay, not that I'm saying you should burn yourself, but that's the amount of gentle heat you want. You just want it to be very gentle. So you whip it across or put it on for a very short period of time just to warm the substance. So.
Thank you. Another question says, does prior partial treatment affect the diagnostic yield for KOH scraping? If so, how can we approach such patients to improve the yield?
Yeah, that's a really great question. And yes, it does. And it depends on what you're treating with. Okay. So if you have someone who's used an antifungal on the area for a period of time and you're trying to do it, it can be very difficult. One, the fungi will be much shorter. They're breaking apart, so they won't be long and branching, and you will have less elements of that. So the way but however, if someone's using steroids, you could either get a huge yield from your scraping, or this is an example where you may need to go a little bit deeper and do a little slit smear because then you can go down the follicle, right? Or find a pustule with it. And so one of the best things to do is either one, try to find an area that hasn't been treated. Two, if you're not sure, ask the patient not to treat and bring them back if that's doable. And if not, then I think you need to make your best judgment, right? If they're improving on antifungal, do that. The ones that are most difficult is when people are using a combination of antifungal and steroid, which we really want to avoid people to use in general, but is still happening. In which case, you really want to try to find either a hard to reach area or an area that someone hasn't treated.
Thank you. Another question, how do bedside diagnostic compare with standard laboratory tests?
Yeah, bedside diagnostics, I think, is just an adjuvant to the standard laboratory tests, meaning in some circumstances, if you submit a specimen for culture, they will perform the KOH or the gram or the slit smear or whatever the case may be. So they are seeing it. But this is a faster, more streamlined way to do it. Either one, when you don't have the laboratory services available. Two, when there's a delay to that. So in some circumstances, you may submit a sample and you may not get a result for 1, 2, 4 days. But they should be quite similar. And the ability of the more someone does bedside diagnostics, the higher likelihood that their ability to identify it like they would in laboratory or as high, right? So if you have more experience in doing it, you'll be more equipped to be able to do it, and you will be at the sort of the same level as a laboratory technician in those cases.
Thank you. The following question, does methylene blue enhance the staining of fungus with KOH? By Linda.
Right, methylene blue is basically I don't oftentimes use methylene blue except for if it's in a Schwartz lambkin or, with a counter stain with chlorizal black. Methylene blue, though, as a separate technique, can be used. So if you have KOH and you add methylene blue to that, it may dilute either one of those and not be helpful. So in this particular case, I think it's more helpful to put 2 slides and use KOH on one, methylene blue on the other. Because the methylene blue, as you saw in some of the examples, will highlight fungus. But I think if you don't have the right formulation and you're trying to do it itself, it may end up that either one of your slides isn't as helpful because the diagnosis of that could be a little bit more limited.
Okay. Does it have to be 20% KOH? Can we use 10%? Moses asks.
Yeah, that's correct. You could have 10 to 20% KOH is totally fine. More than that, it could also be sometimes used, but sometimes I find that it dissolves things a little too quickly. So anything between 10 to 20% is perfect. Yeah, any of those would be applicable.
Thank you, Doctor. This is unrelating, but Chloe says, I am a medical student. Can I join the GLODAM training committee?
Yes, I believe you may. So I would just send an email to get volunteers. I'll let the training committee. I don't know, Cyndy, you take that one.
Yes, definitely. We want students in the training committee, and the earlier the better. So welcome to GTC. And maybe just to add on an answer about how we can compare the bedside diagnostics to laboratory diagnostics. I think also if we look at it in terms of cost, your bedside diagnostics are cheaper and they are faster to do. You get your results faster than the laboratory diagnosis. And then if you think about sample quality, sometimes it's your sample quality is better in your bedside diagnostic because you're taking it at that time and performing the test at that time and getting your results at that time. This is just some of advantages of a bedside diagnostic of a lab, but it is definitely better to integrate the two together for better results. But yes, they're also I think nearly as accurate as laboratory diagnostics for some conditions. Yeah.
I love that. I couldn't agree more. And the way you get to wear the bees is practice, practice, practice.
Okay, I think this is not a question. The last one in the question and answer part, it says, thank you, very clear explanations.
Well, thank you everyone for joining. I'm really passionate about it as well, Cyndy, for bedside diagnostics. And I think we all are taking care of patients to the best of our ability and want to do the best. And I find bedside diagnostics not only so helpful for the patients, but also really fun. And like the more you scrape, the more you're going to learn, the more you're going to find. And getting patients the earlier treatment is really, really powerful and beneficial. And I'll say on behalf of Cyndy and I, we would love to hear from you if you've had positive wins or cases or things like that. We would love to hear you all. I don't know, Cyndy, do you agree?
Absolutely.
So even in the chat, there are no longer questions. People say thank you very much for wonderful presentations, really insightful.
Thank you all. It was such a pleasure to spend some time with you all.
Thank you so much, Dr. Kari and Cyndy. Thank you so much for this insightful presentation. So thank you everyone for joining us for this very insightful session as well. For the students who wants to join us, you can go onto the website as well. There's a column in which you will find steps on being a volunteer. You have to you could be a volunteer currently and then later join the training committee. Thank you very much once more. You can follow us on all social media platforms to hear about our upcoming events, our webinars, programs, and much more. Thank you. Have a lovely day.